Hello, everyone. Thank you for being here. Today's training focuses on a real-world case from my time working at a clinic during a hospital system transition. I'll walk you through the operational problems we experienced, specifically involving credentialing and billing errors, and explain how those issues affected patients, staff, and the organization as a whole. Using research-based methods, we'll also explore what could have been done differently and highlight best practices that healthcare managers can use to avoid similar situations. In 2020, our clinic transitioned to be a part of Cabell Huntington Hospital following the closure of Our Lady of Bellefonte Hospital, our hospital system. We were told that insurance contracts would remain unchanged. However, on opening day, our provider hadn't been credentialed with any insurers. This left every visit classified as out of network and exposed our patients to unexpected costs. According to Knight, gaps in credentialing not only impact operational efficiency, but can also directly threaten continuity of care and trust between patients and providers. This was only the beginning. Our provider was eventually credentialed, but not with every plan we previously accepted. Staff weren't informed of the changes. Claims were processed without awareness that the provider wasn't in network, leading to denials. Because our Kentucky-based clinic sent labs to a hospital in West Virginia, some insurers refused to cover lab costs due to cross-state billing policies. On top of that, the hospital's billing system blocked certain CPT codes from being processed, even when our provider used them correctly. Niedzwiecki points out that disconnects between clinical coding and back-end billing software are a common cause of denied claims and increased administrative burden. The consequences were widespread. We lost over 100 patients in the first few months, many due to financial concerns or frustration over billing errors. Our staff morale declined rapidly. We were fielding complaints daily and trying to fix issues we hadn't caused. Denied claims and rework tasks increased operational strain. Most critically, our provider, who had cared for this community for over 15 years, had her relationships with patients tested. Liebler and McConnell stress that a breakdown in internal coordination can erode patient loyalty and negatively impact organizational culture. Outside of the clinic, the effects of these problems were felt by the wider community. Patients delayed or avoided care altogether due to fear of high bills or confusion about coverage. Some were hit with large, out-of-pocket costs for routine services. According to Kongsvet, poor communication about insurance status and billing responsibility contributes to financial toxicity for patients and fosters distrust in healthcare systems. In retrospect, the root causes are clear. There was no coordinated plan or timeline for credentialing. Our clinic had no contact with the credentialing or payer relations staff, and since this was a new hospital affiliation, we had no contacts to reach out to for help with this. Planning around lab services was non-existent, and we didn't realize that out-of-state lab billing would be an issue. Successful credentialing requires clear accountability, consistent communication between departments, and complete verification before a provider sees patients. Credentialing oversight should be centralized with clear timelines and verification steps. Forster et al. Recommend no provider should see patients until credentialing is fully confirmed. Knight adds, credentialing isn't just a business process, it directly affects clinical outcomes and patient trust. Clinics need access to up-to-date insurer enrollment lists to prevent these types of mismatches. Revenue cycle best practices start at the front end. Eligibility verification should happen before patients arrive. According to Niedzwiecki, training staff in billing processes helps prevent denials and improves communication with patients about their coverage and responsibilities. Adding another lab partner also allowed us to serve patients whose plans didn't accept our default lab. To fix what we could, we implemented a low-cost lab event every other month to reduce financial strain on patients. We added LabCorp as an in-network lab for many plans. When necessary, we obtained prior authorizations. Several staff, including myself, pursued certification in billing and coding to improve our internal knowledge and reduce errors. These efforts align with recommendations by Liebler and McConnell, who note that staff development plays a vital role in strengthening operational performance. We learned a lot. Credentialing should always be completed before the clinic opens. Even small details like lab location can disrupt the entire billing process. Staff who work on the front lines often recognize problems early. Supporting staff in pursuing additional training and encouraging their feedback can lead to practical solutions that leadership might overlook. To avoid these problems in the future, we need to follow several best practices. First, credentialing must be finalized before the first patient is seen. Regular insurance updates should be shared with clinic staff. Real-time analytics around lab denials and billing errors can help leadership spot problems early. And investing in staff training helps build a more resilient team. Continuous education and clear communication are essential to delivering efficient and patient-centered care. One of the most important missed opportunities during our transition was the lack of structured leadership coordination. If we'd used an interdisciplinary planning team involving operations, billing, credentialing, IT, and frontline clinic staff, we could have flagged gaps in the process, such as incomplete insurance enrollments or lab billing conflicts, before they reached the patient. In fact, Langabeer and Helton recommend using lean healthcare principles during operational change. These principles focus on eliminating waste, reducing unnecessary handoffs, and using structured workflows with clear checkpoints. A lean approach would have helped us map out the credentialing timeline and the lab workflows and spot breakdowns earlier. Beyond the structure itself, the role of the manager is central. Managers act as liaisons between clinical and administration teams. When they're empowered to raise red flags early and included in planning discussions, they can prevent small issues from becoming systemic problems. At our clinic, if we had been consulted before the transition was finalized, we could have pointed out that we weren't receiving updates about payer contracts or billing parameters. Another key element is clarifying roles and responsibilities during credentialing. According to Liebler and McConnell, unclear expectations and siloed processes are leading causes of credentialing delays. If timelines had been clearly assigned to the credentialing department with feedback loops to the clinic, we might have avoided seeing patients while our provider was still out of network. One of the most frustrating parts of this situation for patients was the lack of communication. We didn't warn them that network participation had changed or that some lab claims could be denied. According to Kongsvet, managed care systems must clearly communicate plan participation and service limitations to protect patients from surprise costs. We also didn't equip our front desk staff with tools to help them verify coverage in real time. As Niedzwiecki notes, front-end verification is essential to preventing claim denials and improving transparency at check-in. Simple solutions like using standardized scripts, handouts, or FAQs could have helped patients understand why they might owe more than expected. Liebler and McConnell emphasize the importance of training staff to communicate policy changes effectively and compassionately. Hospitals today are using real-time data not only to manage capacity, but also to predict operational strain. Jank and Venkatesh suggest using dashboards that flag likely bottlenecks or problem areas In our case, having a system that alerted us to frequent out-of-network lab denials could have helped us act faster before patient harm escalated. What this experience taught me is that operational failures in healthcare don't usually come from bad intentions. They come from gaps in planning, communication, and follow through. Transitions like the one we went through should always involve cross-functional planning teams that include clinic leaders, billing, credentialing, and patient support staff. When these voices are included, the risk of overlooking important details drops dramatically. Patients should never have to navigate network or billing confusion alone. Healthcare managers have a duty to protect both patients and frontline staff by communicating clearly, planning early, and responding quickly. Langabeer and Helton point out operational efficiency isn't just about speed, it's about getting it right the first time. Strong leadership rooted in evidence-based practices and team empowerment is how we turn challenges into progress. With the right structures, training, and mindset in place, we can avoid these breakdowns and create systems that actually work for everyone involved. Are there any questions? Thank you.